Good evening, ladies and gentlemen. Welcome back to this second edition of Cancer and I, which we are bringing to you in conjunction with World Cancer Day, which happened on the 4th of February. So, and this week is the second installment of that series. And we are very privileged and honored to be able to have with us tonight three very distinguished consultants who are going to spend quite a bit of their actually very precious time and share with us some insights and some learnings for all of us to take home about different aspects of cancer. So this evening, we are our partner for this session is KPJ Ampang Putri, and we have three very distinguished consultants with us from KPJ Ampang Putri. And first up, starting off this evening, it seems that every time so far we always have an oncologist to kind of kick off the evening, and today is no exception. And we're very privileged to have Dr. Azura Daniel, who is a consultant clinical oncologist with KPJ Ampang Putri. So good evening, doctor. Thank you so much for joining us this evening.
Hi, good evening, Dr. Murali. Thank you for inviting us.
Oh, always a pleasure. Kongsi Fatai, Kongsi Fatai.
You too.
Yeah, and we'll actually like to kick off this evening and kind of ask you to share with us a little bit on. I think the title today was on before or after, and a little bit about Neoadjuvant Therapy. This new kind of terminology and therapeutic kind of idea that's come into cancer management. So we're hoping we can kind of get you to provide us a little bit of information on this, Doctor. And as we kind of kick it off, I'm actually going to start the evening by asking you the famous question that I was asking everyone in the last session. So how come oncology, Doctor? Why oncology?
Okay, so I guess incidentally, I think I have a very strong family history of cancer.
Oh dear.
First
Okay.
degree relatives, second degree, and also third degree relatives. So I've seen a lot of cancers around me, and I've had quite a lot of survivors as well in the family. So I think that sparked the interest, and I had the privilege during my early years in medical field, where I was introduced to help out in oncology clinics and also palliative care. So I think I started from there. Moved
Oh,
on to KL to join HKL, and then went on to do the training as well.
oh, right, Doctor. So you've been are you a KL person?
No, I'm actually from Perak, and I
Ah.
started working in Ipoh Hospital. So
Oh, okay, okay. So and then you've kind of we brought you over to KL so that they
yeah,
transplanted
yes.
here already lah. Right, right. Okay, good. Lovely, Doctor. So without further ado, I'm actually going to ask you to kind of kick off the evening, Doctor, and talk to us about this new thing about neoadjuvant and adjuvant therapy. What is this thing about, Doctor? I would really love to turn over the screen to you.
Okay, so I'll share my screen. Yeah. Okay. First of all, on behalf of KPJ Ampang Putri, I would like to thank NCSM for inviting us to join in with the activities for World Cancer Day 2021. And today I'm going to kick off with talking about adjuvant or neoadjuvant therapy. I guess firstly, I would like to say that cancer treatment is very complex. Most patients would actually need multi-modality therapy. And that is why we usually say cancer treatment as like a journey, a cancer journey, because even each type of modality of treatment will require multiple courses, multiple cycles of chemotherapy, multiple fractions of radiotherapy. But within that multiple types of treatment, there will be one main treatment that is the most important. This treatment is the one that is considered the definitive therapy or the main treatment that will be the most important thing that will induce cure for the patients. On top of that type of treatment, then there will be additional therapies that will be given either before or after the main treatment. The intention is to improve the outcome of the disease. So that brings us to the concept adjuvant or neoadjuvant therapy. So actually, adjuvant and neoadjuvant is not that complex or not that difficult. It just actually describes the sequence of the events, sequence of the treatment, and it also actually describes the intent of the treatment. So most of the time when we say adjuvant or neoadjuvant, these patients are still being treated as a curative intent. And when we say adjuvant, it's usually therapy that is given after the main treatment, or we can also say something like additional treatment that is given in absence of detectable disease. But when we say neoadjuvant, in contrast, it's treatment that is given before the main treatment, i.e. the treatment that is given prior to definitive or curative therapy. So what are the types of treatment that can be given as adjuvant or neoadjuvant? Actually, there are multiple types of treatment. Most of the time, patients will have chemotherapy. Sometimes they will have radiotherapy. Chemo and radiotherapy can also be combined together and given as concurrent chemoradiation. Some types of cancers may also benefit from other types of treatment like hormonal therapy and targeted therapy. So just to illustrate this even further, a patient is diagnosed with cancer and she will be planned to have the main treatment in the intention of having cure. But to improve the outcome even further, then we will add on adjuvant treatment. So adjuvant treatment is given after the main treatment, or she will receive neoadjuvant treatment. That is treatment that is given before the main treatment is given. So as an example, if you have a patient with a colon cancer at diagnosis, then he would most probably just undergo the main treatment, surgery first, and then after that, it will be followed by adjuvant chemotherapy. And this adjuvant therapy usually will be about 6 months of treatment to maximize his chance of cure. Or a patient diagnosed with breast cancer, so at diagnosis, then she would be planned for the main treatment, which is surgery. And for her best chance of cure, sometimes she would be considered for either neoadjuvant therapy before surgery or adjuvant therapy after the surgery. There will be times as well where they will have all of this. So at diagnosis, have neoadjuvant treatment first, and then surgery. And after that, they will also go on to have adjuvant treatment, which may include chemotherapy, radiotherapy, hormonal therapy, and targeted therapy. And this will give them the best chance of cure. What is the rationale of giving all this treatment, additional treatment? Well, the rationale for adjuvant therapy, giving treatment after the main treatment has been done or after the tumor has been removed, is mainly to destroy the remaining cancer cells that may be present in the body. And what I call it something like sterilizing the cells in the body. And the aim is to reduce the risk of recurrence and improve the survival even further. And the types of therapy, as mentioned, can be multiple types of therapies. Usually it's chemotherapy and radiotherapy. So how do we decide whether the patient will need adjuvant therapy or not? It depends on multiple factors. One of it is the type of cancer. So there are types of cancers that do benefit from adjuvant treatment, but there are also cancers that doesn't benefit from adjuvant therapy. So cancers that do benefit from adjuvant therapy are usually breast cancer, colon cancer, lung cancer. Cancers that do not benefit from adjuvant therapy are something like renal cancer or liver cancer, then they might not benefit from adjuvant therapy. And also stage of disease. So most of the time, the adjuvant therapy is beneficial for those who are stage 2 and stage 3. Stage 1, occasionally they may still need adjuvant therapy, or they may just have one single main or definitive therapy. Age is also a factor where younger patients may benefit more from adjuvant therapy. Patients who have multiple comorbidity or multiple other medical problems may not be suitable for adjuvant therapy because of the risk of the treatment. So this is one of an example of the benefit of adjuvant therapy that has been studied. So the study actually involved around 100,000 breast cancer patients who's been treated with adjuvant chemotherapy compared to those who were not treated with adjuvant chemotherapy. And it has been shown that by giving this adjuvant treatment, you actually do reduce the risk of recurrence. you actually improve the breast cancer mortality rates and overall mortality rates. And the graphs here also show a clear separation between those who had chemotherapy. The risk of mortality is lower compared to those who didn't have chemotherapy. The risk of mortality is higher in terms of breast cancer mortality and also overall mortality. Let's go on to neoadjuvant therapy. So what is the rationale of neoadjuvant therapy? I think traditionally what we used to do in terms of neoadjuvant therapy is to downstage the disease. So when we are faced with a patient who come to the clinic with very large tumors, advanced disease that is not operable, then we have to give additional treatment to reduce the size of the tumor and hopefully render the tumor from being inoperable to operable. Now we are moving forward to also use neoadjuvant chemotherapy to try and plan for better surgery. For example, a breast cancer patient who comes in with a tumor that may cause her to have total removal of the breast, which is called mastectomy. By giving neoadjuvant chemotherapy, sometimes you can actually shrink it and allow for breast conserving surgery to be done, which is a better cosmetic result for the patient. And also an example of rectal cancers, where if a patient presents with low rectal tumors that is close to the sphincter, having surgery up front may cause the patients to have to undergo surgery with a permanent stoma. But if you allow the patient to have neoadjuvant chemo radiation, then there is a possibility that the tumor may shrink and we can actually preserve the sphincter and the patient doesn't have to have a permanent stoma. So that is another way of benefiting from neoadjuvant therapy. And we have moved on even further by giving neoadjuvant chemotherapy to improve overall survival of the patient. And this is by trying to achieve a pathologic complete response, especially for breast cancer. It has been shown to be beneficial, and I'll explain about this a bit later. I hope this is not too scary for you all. So an example of a patient who had locally advanced disease presented before any treatment and had to undergo neoadjuvant chemotherapy. And after neoadjuvant chemotherapy, you can see that the tumor has shrunken quite well, and the patient managed to undergo surgery with a good result. So that is one of the roles of neoadjuvant chemotherapy. And also an example of a scan, a patient with a locally advanced rectal cancer. The tumor is actually right at the center. You can see there's a large tumor, rectal tumor, before treatment. And after treatment, the tumor has shrunken significantly, and that allows for a better surgery to be done. So let's go on to pathologic complete response. It may be a new term for some of you, but actually it's an important term in terms of neoadjuvant therapy. Pathologic complete response is described as a complete disappearance of invasive cancer cells in tumor tissue and lymph nodes after neoadjuvant therapy. So what it means is that after you give neoadjuvant therapy, the tumor disappears clinically, where you can't actually visibly see it anymore, and also pathologically, where you, even if when you look under the microscope, then the tumor cells are no longer there. And if we are able to achieve this pathologic complete response, then the chance of improved survival is much better. And multiple therapies that can be given. One of an example is giving dual targeted therapy for breast cancer with chemotherapy. You can get up to about 40% pathologic complete response rates. And this actually induces a better survival result for these patients. And this is another graph showing a survival curve for these patients. You can see that those with total pathologic complete response have a much higher survival compared to those who didn't. And if we look at the overall survival, 9-year overall survival for those that achieved PCR, it's about 80% overall survival, which is very high for breast cancer patients. So there are many types of cancers that may be suitable for neoadjuvant treatment, and I think the list goes on even longer nowadays. These are some examples. breast cancer, those with locally advanced or inoperable disease, those who are triple negative, HER2 positive, and more than 2 centimeters would benefit from neoadjuvant treatment. Rectal cancer with threatened surgical margin. This actually describes the surgical outcome when they do the surgery to make sure that everything is removed completely. So if it's not able to be removed completely, then they would benefit from neoadjuvant treatment. Esophageal and stomach cancer also increasingly being used, bladder cancer as well. So I hope I've managed to explain the term adjuvant and neoadjuvant. It's not very complex, I think. It's merely to describe the sequence. So adjuvant is additional treatment that is given after the main treatment or after surgery, and it aims to improve survival and reduce risk of recurrence. Whereas neoadjuvant in sequence is given before the main therapy is given, and the aim is mainly to downstage disease, allow for better surgery, improve survival, especially if we can achieve pathologic complete response. I think that's the end of my talk. And I'm an oncologist, and I will do my best to treat and cure cancer, hopefully.
Thank you so much, Doctor. Very interesting and I think enlightening kind of idea and sharing with us about this adjuvant and neoadjuvant. And really, I think it's still a very, although it's not so new for oncologists, I think for patients it's still quite a new term. And if you are okay, there's a couple of questions that we have already. Would you be able to take some questions, Doctor? Some of them are quite interesting. So there is a question, and I think a lot of people are quite aware about neoadjuvant therapy in breast cancer. I think it's become a lot more common to discuss it, but I think not so much with the other cancers. So I think that's also a lovely point that you've kind of pointed out, that rectal cancer, bladder cancer, esophageal and stomach cancers, these are cancers that we should be thinking about neoadjuvant when we are discussing management of the patient, Doctor. So there's a question from a patient on, I'm a breast cancer patient. Why do I need neoadjuvant therapy when I can do surgery to cut off the tumor first?
So as I explained just now, I think there are some types of breast cancer that will actually benefit even more if they receive neoadjuvant therapy first, even if it's operable upfront, especially if it's HER2 positive and triple negative, then the rate of pathologic complete response is actually high, and that will translate to a better overall survival for them. So that's where we are moving now, trying to give more neoadjuvant for those group of patients.
Right. So two points, Doctor, which I think is worth kind of clarifying. I think one of the very interesting things that you were mentioning was the fact that actually neoadjuvant doesn't necessarily just mean chemotherapy or now targeted therapy. You were talking about how it could be radiotherapy as well, Doctor.
Yes, yeah.
Okay, and I think another, so just to share that neoadjuvant therapy does not only mean kind of chemotherapy or targeted therapy. And just coming to that point as well, I think Dr. Azura was highlighting very relevant point, that she was talking about suitability for neoadjuvant therapy, and she used actually the term about being HER positive or triple negative, and I think that's a kind of an important point that we need to kind of drive across to patients as well. Make sure that you actually get your kind of immunohistochemistry done. Isn't that true,
yeah,
Doctor?
That's the most important now for breast cancer. It's like a passport. You need to have it done. If not, we can't really decide what treatment we should do for those patients.
Right. So, and then I think this is one of the concerns with quite a bit of the patients, and I think Dr. Azura is kind of strengthening this point as well, that very often, because your immunohistochemistry comes on like a kind of additional, it feels like it's an additional testing. So, and then so there's sometimes this idea from patients that, I'm already paying so much, for the biopsy. Now you want to ask me to pay some more money. Now I think I can do without this, or maybe we can do it later. So I think one of the things that I think Dr. Azura will affirm for us is how important this testing is, Doctor.
Yeah, it should be done upfront, like automatic testing, diagnosis of breast cancer, even on the biopsy specimen. But sometimes the labs, we have to request a second time, and then the payment will have to be made a second time. That's why it feels like a burden to some.
Yep. And then, so really, ladies and gentlemen who are listening, I mean, it's not that I think the doctors or the hospitals trying to like pow you for more money, lah. Really, I think sometimes now it's something that they need to discuss with you, that, this is an investigation that needs to happen. So it's going to cost a little more. But I think now, rather than being a nice add-on, as in like, I mean, horrible example, but it's like if you buy nasi lemak, you need sambal. You may have an option of getting like ayam goreng ke, sambal sotong ke, but the basic ikan bilis sambal has to be there lah. So what we're trying to say is, I think immunohistochemistry now is part of the sambal of the core of the nasi lemak lah, kan? Betul tak, Doctor? Yeah, I think it's something like that lah. And so really, if there's a point to be made about neo-adjuvant treatment as well, it's the fact that I think we need to upfront already have this idea that you need to test to look for the suitability of receptors. Okay, yes, doctor. And also, doctor, there's another interesting question. Can I just do surgery without neoadjuvant or adjuvant therapy at all? I think this is
It depends on the type of cancer as well, whether it benefits from neoadjuvant treatment or not. So if we know, like rectal cancer, most of the time they will need neoadjuvant. Like Dr. Osama will explain later. Breast cancer, it depends on the subtype, as mentioned.
Right. And doctor, there's this other question on whether if I have done a neoadjuvant and then now the cancer has shrunk, the tumor has shrunk, do I then still need to go for surgery?
Definitely.
Okay.
As mentioned, I think for each cancer, there will be one definitive therapy that will be the treatment that will induce a cure. So for breast cancer, surgery will be the most important treatment. So you cannot avoid surgery.
Right. And I think, again, to come back to Dr. Azura's slides that she was showing to us earlier, we talked about neoadjuvant therapy, we talked about adjuvant therapy, and we talked about the main therapy. Isn't that true, doctor? So, and in most in these cases, when you're talking about using surgery as the main therapy, that is the option, and it's only really to strengthen that option that you're either considering like complementary therapy.
Yes.
Again, I suppose horrible example to give, but it's the surgery is the nasi in the nasi lemak lah,
So, you cannot not have the surgery.
Tak ada nasi, macam mana nasi lemak kan? So that is perhaps the weird but accurate example. There's one more question, doctor, and I'm wondering. Oh, this one is. I think I will ask you as well, and then maybe we can try Dr. Adita on this question as well, because this one might start off one interspecialty war. This is on the oncologist recommends neoadjuvant therapy first, but the surgeon recommends surgery first. Who do I think? Who should I listen to?
So usually it would be good to have an MDT, multidisciplinary discussion, where the doctors will sit down together with the patient, if possible, to decide the best option of treatment. Yeah.
Oh, okay. And isn't that being done in KPJ Ampang Putri as well, doctor?
Yes, we do that quite frequently. Yeah.
Right. So again, and perhaps this is a good time to kind of enlighten patients a little bit on the decision-making process in terms of management as well, because sometimes patients have this idea that, hey, I came to see the doctor, and the doctor said, no, I have to speak to someone else, and then come back like this doctor, like not so pandai like that, you must go and check a book. No, so that's not what's going on. What is actually happening is actually standard of care, in which there's actually a consultation between like different disciplines. It's like a multidisciplinary check and balance where they decide what is the best for you. So actually, I mean, I'm being a horrible Malaysian and telling actually you untung, because basically you're getting free two for the price of one lah. There's two doctors, three doctors kind of consulting before you
have it like at least once a month, but because of the current PKP and all that, well, we have to postpone a little bit, but we can do it still online.
Right, exactly. And I'm sure you all just like kind of go over a closed channel to speak to a colleague
Yeah.
and kind of get an opinion. So that's how actually treatment is actually kind of decided on for individual patients. And I think it's a good kind of idea to that Dr. Azura is sharing with us on how that process takes place as well. Doctor, there's just one more question. And if you have had neoadjuvant therapy and then surgery, do I still need to get chemotherapy after or radiotherapy as after this too is done?
So I think the best example would be breast cancer,
Mhm.
where you have multiple options of treatment, and most of the time, each of the treatment has its own weightage to improve the outcome of the disease. So yes, patients who have had neoadjuvant chemo, most of the time will have to undergo some form of adjuvant therapy after the surgery, where they will still have to undergo radiotherapy, maybe some more targeted therapy, or complete the chemotherapy and also hormonal therapy. But
Right.
take it as a positive point, where each treatment that you have to undergo actually gives a better benefit for you. So individually, they will add up, and
Yep.
you have a better outcome.
Right. So that's also another very good point. It's not that we're trying to, in management of cancer, I think what Dr. Azura is kind of stressing is the fact that there's the more weapons we have to throw at the cancer, then the less the likelihood of the cancer coming back. So it's
Yeah,
not an idea of, and again, this is a common misconception, is like we adding unnecessary therapy.
yeah, yeah.
Yeah,
Mhm.
a lot of
It's all
people
based
have
on
that
evidence.
idea. Yep. Yep. Doctor, there's one more question, and I'm going to see whether is it okay for me to kind of squeeze that onto you, doctor?
Sure, sure.
Okay. There's one about what about non-operable lung cancer? Is there a role for new adjuvant to play in this, or is even new adjuvant in this discussion?
Yeah, lung cancer is a bit more complex. I think there is some trials on the role of neoadjuvant treatment, but it's not that well established.
Mhm.
But if the disease is non-operable, then there are a few things that can be considered. So either we go on to straight away give chemo radiation as the main treatment to replace the surgery, or we can also try neoadjuvant chemo and see whether it can be operable later. So I think it is still an option.
Right, right, and so, ladies and gentlemen, I think if anything, the idea from this first session has really been to kind of give you an insight to the idea that look, there may be some other options available which can strengthen surgery as the kind of main treatment. I think new adjuvant is one of those options, and new adjuvant therapy can come in many forms. It's not just conventional chemotherapy, it can be targeted therapy, it can be radiotherapy. And again, and I think this discussion will continue having throughout the series, it's very individually based. So it requires both the expertise of the oncologist and the multidisciplinary team, the primary physician, be it the surgeon, the colorectal surgeon, the breast surgeon, working together to kind of figure it out. Because if no means, it will become a McDonald's Happy Meal. Buy one and tick tick, and you can get fries. So it doesn't quite work that way as yet, lah. Which is why I think oncology is more an art rather than as well as it being a science. Kan,
Definitely.
doctor?
Yes.
Yep. Yep. Okay. So as we're wrapping up with Dr. Azura this evening, doctor, can I ask you for a takeaway message for our viewers today?
So I think I hope they all understand what I was talking about just now about neoadjuvant and adjuvant, and don't be afraid of having multiple treatments, as each of these treatment are actually evidence based, and they all contribute to have a better outcome for the disease.
Right. So thank you very, very much, Doctor, for sharing with us this evening. And we hope to see you very soon. And Dr. Azura is a consultant clinical oncologist in KPJ Ampang Putri. So as we end the first segment with Dr. Azura, we're going to thank her very much. And we're going to get on. Thank you, Doctor. Good evening.
Thank you, Dr.
Uh,
Mali.
and we're going to get on Dr. Anita. And Dr. Anita is a consultant breast surgeon who is with KPJ Ampang Putri as well. And we are actually very fortunate this evening to be able to get Dr. Anita here with us. And Dr. Anita is going to be sharing with us a little bit more on the similar kind of idea, on the same line of the discussion as Dr. Azura kind of laid out this evening, which is on neoadjuvant therapy as well, but in the context of breast cancer. Good evening, doctor. How are you? You
Hi,
still
Dr. Morali.
Good
Hi.
evening, doctor. How are
Good
you?
evening. Yes, yes,
Pleasure,
I'm well.
pleasure.
How are you?
I'm very good. Thank you so much for joining us this evening. It's such
Yeah.
a privilege as well.
Yeah, it's a
Uh,
pleasure to me.
Thank you.
Thank you
Lovely,
so much for
lovely, doctor.
inviting.
Oh no, it's really our pleasure. We were just, I think, speaking a little bit with Dr. Azura about neoadjuvant therapy, and I
Yes.
think I was just saying to Dr. Azura as well that one of the kind of popular areas in which everybody speaks about neoadjuvant therapy is breast cancer, doctor. So we're
Yeah,
hoping
yes.
you'll be able to provide us with a little bit more details on this. But just before that, I was just going to ask you to kind of
Okay.
tell us a little bit about yourself and
Okay.
and uh, and how did you end up in breast surgery?
Assalamualaikum and good evening, everyone. Thank you, Dr. Morali. I'm Dr. Anita Bagawi, consultant breast and endocrine surgeon. I did my undergraduate study in University Kebangsaan Malaysia. That was way back in I graduated in 1995. Then working in Penang GH for almost 3 years. I think almost 12 years. Then I pursue my master's in surgery, then proceeded with subspecialty breast and endocrine surgery under Tan Sri Nur Hisham, Dr. Nur Hisham.
Okay, so you're a student of the man of the hour.
He's my sifu.
Lovely, doctor. Yes, so you were saying, doctor, why breast and endocrine? How come?
Okay. I was working very closely with one of my consultant in Penang GH, and the late Miss Susila Muniandi. She was previously in Selayang after she was transferred from Penang, and I think the most is Tan Sri Nur Hisham was my senior in University Kebangsaan Malaysia when I did my undergraduate study, and so I got to know that he was in HKL and Putrajaya, and he's the trainer for breast and endocrine. And I think we need more lady female consultants, or even in general consultants, surgeon in breast, especially in breast surgery, and as well as endocrine.
Okay. Lovely, doctor. Then doubly, thank you so much for coming into the profession
Thank you.
and kind of helping to level the playing field and having more women in this field as well.
Yeah.
Yeah. Doctor, so today you're going to speak to us a little bit about neoadjuvant therapy in breast cancer. So
Yes, yes.
please allow me to turn the screen over to you so that
Yeah.
you can kind of share with us these insights.
Yes, let me share my slides.
Lovely, doctor.
Is that okay?
I can't see it yet, doctor.
You can't see my, oh, it's on my, hold on. Oh dear. Oh, you can't see my screen?
No, I can't see this yet.
Oh, sorry, I thought I have. Oh dear. Okay, and show, let me do it again.
Okay, no problem, doctor.
Okay, I thought, oh, it's taking. Okay, I'll do it again, Dr. Murali.
Okay,
Not
no
sure
problem,
why.
doctor. If not,
Yeah.
just to share with you that I have your slides up as well. If you want me to share the screen.
Because it's a different. I
Okay,
have
no problem, doctor.
added on few things. Hold on. Okay. Can you see that?
Lovely, we have it,
Okay.
doctor.
All right. Let me put it in a slideshow. Oh dear. Oh, I couldn't get it on the slideshow now.
I think if we hit that button at the the left,
Yeah.
that one.
Yeah, but I
Okay.
couldn't get it. Hold on.
Ah.
Oh, it was okay just now. I'm so sorry about this.
Oh, no problem, doctor. Don't worry.
Ah, dear.
But actually, it's quite clear for us as well, doctor. If you want to just carry on, fine
Is
as well.
it? Can I
Yep.
just carry on?
Yep.
Oh,
No,
dear.
no problem.
Okay, but I couldn't really see some of my presentation because of the okay, let me see. One view. Okay. Never mind. I think I can proceed.
Sure.
So I'll be presenting on neoadjuvant therapy in breast cancer. And sorry, Dr. Murali, I think I have some problem with the slide now.
Doctor, maybe it says maybe that slideshow. There's a button on your right that says slideshow play. Would that help? Okay.
Oh dear. Okay, new share. Can I go to new share?
Yeah, sure, doctor. You want to try?
All right.
Shall we
Yeah.
try this again?
New sharing, or just stop sharing. Follow.
Okay.
And I will share my. Okay.
Okay. It looks to have.
It's still the same. Gosh. Maybe this one. I think my slides are stuck.
Okay, no problem, doctor. If you could stop sharing, and then what I'll do is I'll put up the slides, then maybe we can see the additional slides that you wanted to put up.
Okay. All right.
Okay.
Very sorry about this.
No problem, doctor. Small issue.
I don't understand why I couldn't get this.
Okay. Is this okay, doctor?
Yeah.
Okay. Just tell me when you want to switch the slides. Yeah.
Yeah. Okay. Because I have added on few more. Or maybe Dr. Murali,
Yes, doctor.
Can we proceed with Dr. Osama first and let me settle the...
Actually, yeah, no problem. Why don't we do that first?
Yeah, very sorry
okay.
about this. Let
No
me...
problem. Don't worry about it. Okay, let me get Dr. Osama. Good evening, Dr. Osama. Are you available, doctor?
Yes.
Okay, lovely. Okay. Hi, Dr. Osama. I'm sorry. You're currently being brought out to bat first. Thank you so much for coming on, and I'm hoping you can give us a few minutes so that we can let Dr. Anita sort out the slides so we can run your segment first. Apologize for the kind of switch in the batting order.
No, we're ready. No problem.
Okay, lovely, doctor. So thank you very much for joining us this evening. So everyone, that was a taste of Dr. Anita, and then we're going to leave you and come back for more in a bit. But in the meantime, please allow me to introduce Dr. Osama, this distinguished gentleman who is a colorectal surgeon, who's a consultant colorectal surgeon with KPJ Ampang Putri. So Dr. Osama is going to speak to us a little bit about colorectal cancer this evening. And there's a lot of also in colorectal cancer, this kind of confusion with patients, doctor, and I'm sure you face this as well, because new adjuvant therapy is something new. People are very concerned on, oh, why don't I cut first and then do my chemo later? Why are you asking me to do chemo earlier? Why are you asking me to do this new targeted therapy in colorectal cancer? So the noise around new adjuvant therapy in colorectal cancer is a little bit less. And so there's lack of understanding as well. So we're hoping that Dr. Osama is going to help us change that perception a little bit today. So first of all, Dr. Osama, please allow me to thank you very much. Wish you a very good evening for joining us, and ask you to say, if you could kindly say a few words about yourself.
Yep, good evening. Thank you very much first to Dr. Murali for having us on. I want to thank the National Cancer Society as well for having these kinds of sessions, which are very useful to communicate information to the public. I want to thank my fellow presenters today, Dr. Azura, of course, who I work closely with, and we do discuss about this neoadjuvant therapy quite a bit regarding our patients that we get here in Ampang Putri. So we do work very closely. Of course, Dr. Anita is also a colleague of ours, but she's more specialized in breast surgery. Now, I'm a colorectal surgeon, and my background is I'm a student of University Malaya, undergrad, postgrad as well. I was a lecturer in the university as well for a while. And then I pursued my subspecialty training in colorectal surgery, as I was inspired by many of the colorectal surgeons around me, and completed my training in Edinburgh, Scotland, and came back here, and now I'm in KPJ Ampang Putri. So that's a very short, quick introduction.
Lovely. Thank you so much, Doctor. A curious question. Why the colorectal, though?
Right. Well, as I mentioned earlier, of course, when you are practicing in government hospital and a university hospital, you get to see all the specialties firsthand, and then the inspiration by certain individuals. In my case, was Professor Dr. April Roslani, who's the president of the College of Surgeons of Malaysia now. She was the colorectal surgeon then, and the inspiration was there, and the drive was there, and then we kind of got into it. And the other reason is actually because of the challenge. It's a challenging field. It's very difficult. It is very wide. There are benign disease, there's cancer disease, there is the open surgical methods, there is the keyhole surgical methods. Now we have the robotic methods. So there's a vast array of things that can be done. So the more, the merrier.
Right. Lovely. Thanks, Doctor. Wow. It's quite inspiring to see what is this? Someone who's really gone into this area. Usually people be like, it's not as sexy. Yes, Doctor. So this evening we were kind of hoping that you would give us a little bit info on adjuvant and new adjuvant therapy in terms of colorectal cancer, Doctor. So I'm just going to turn the screen over to you so that you would be able to share with us.
Is it okay there?
Yes, Doctor. Lovely.
Excellent. So again, thank you very much for this opportunity to present about neoadjuvant therapy in colorectal cancer. And I believe Dr. Azura would have covered quite a bit on neoadjuvant, but I also wanted to say a few things about it before we move on into more details about colorectal cancer in particular. So as we all know, and I hope that people know that actually colorectal cancer is the third leading cause of cancer death worldwide. In fact, in Malaysia, it is the commonest cancer in men, and it's the second commonest cancer in women. So despite it being not so particularly well known, it is very, very common. And in fact, I believe that our numbers are increasing year over year. because we're seeing more and more patients having this problem. Now, I just wanted to give a very simple definition on what we mean by adjuvant and what do we mean by neoadjuvant for patients who are out there listening. Now, the idea of adjuvant therapy is, of course, is by definition is to serving to aid. That means to give a hand, to lend a hand, and to contribute to the treatment. In adjuvant therapy, usually which comes after surgery, it enhances the effectiveness of the surgical outcome, and it gives a systemic, which means we're giving treatment to the whole body after completing the treatment for the local disease. Now, in neoadjuvant therapy, it's slightly different because we are giving systemic therapy. That means we're treating the entire body first before we zoom in on the local disease. And either way, in adjuvant or neoadjuvant, we have many modalities. You know, as Dr. Azura mentioned earlier, we've got chemotherapy, we've got radiotherapy, we've got a combination of both. Now there's immunotherapy as well that's coming in. So there's a lot of options. Now, the main difference, and I think this is important for people to understand, is that when it comes to adjuvant therapy, the treatment is based on the staging from the tumor itself, because the tumor has already been removed. It has been tested by a pathologist. We've got the entire result of everything we need to know about the tumor, and therefore the treatment is based on that. Whereas in neoadjuvant therapy, a lot of our treatment in terms of radiotherapy and chemotherapy, it depends on radiological diagnosis. And what I mean by radiological diagnosis is from looking at scans, especially CT scans, MRIs, and even PET scans. So based on that, then we decide whether we need to give neoadjuvant therapy or not. So there's a difference between, a glaring difference between adjuvant and neoadjuvant, especially when it comes to colorectal cancer, which I will come to in a short while. Now, what is the purpose of doing this neoadjuvant therapy? Is basically we want to improve the control of the disease. We want to also improve the control of the disease within the entire body. We try to, give an idea of how this disease is going to respond when we give it neoadjuvant therapy. Is it going to be a good response? Is it going to be not a very good response? Do we need to change the medication after the surgery? And in many cases, with the rectal cancer specifically, we are sparing some part of the organ that we require. And in terms of rectal cancer, I mean the control mechanism, what we call as saving the sphincter. So sometimes this neoadjuvant help us to save the sphincter and the control for some patients. Historically, in terms of how did this all started, because we started giving treatment, systemic treatment like chemo and radiotherapy to patients who could not be operated on. So not in the patients who the tumors are too big, or they're too invasive, or they're affecting too many parts where surgery becomes a problem, or it has already spread to other places in the body, then surgery may not be an option. And we started to give these treatments, and we've seen over time how it is affecting the tumor, and maybe some of them were converted later into patients who are actually fit to go for surgical treatment. And this was very, very important actually, because there was at some point before neoadjuvant therapy where a lot of patients may not have had any surgery, and because of this neoadjuvant, we have converted them into patients who can go for surgery and potentially can get cured. Because our aim in colorectal cancer is always to try to achieve cure. So whatever we do, whether it's surgery, whether it's neoadjuvant therapy, whether it's adjuvant therapy, our aim is for cure. And But in terms of neoadjuvant specifically, to put everything into one big group as colorectal cancer, I think it is not very accurate. In fact, we like to think of it as two distinct entities, which means there's two different things. We've got the colon cancer part, and we've also got the rectal part, because the treatment for these two parts is different. Therefore, we don't lump it up all in colorectal cancer. We would say neoadjuvant for colon cancer or neoadjuvant for rectal cancer, because they are two different groups. And the reason is, of course, rectal cancer, to begin with, the location, it is confined within the pelvis. It is just that segment, which is 12 to 15 centimeters. It is a very specific area. It's got a very specific blood supply. It's got a very specific lymphatic drainage. And obviously, radiologically, also, when we look at it with the magnetic resonance imaging, MRIs, we can get really good pictures of what is going on within the rectum and the area surrounding the rectum within the pelvis. And when we talk about radiotherapy in particular, because it is a confined space and because it's within that narrow space, you get a really good response from radiotherapy because it is very focused and is very concentrated into that one area. We can't say the same about colon cancer because it is such a long segment that is traversing the entire abdomen. It's all over the tummy. So maybe radiotherapy may not be as effective because it's such a bigger area, such a wider space, and there's a lot of dispersion. So you may not get the same result. And this is one of the other reasons for this differentiation is because surgery on the rectum also has its advances, where we are taking not only the rectum, but the entire tissue in that pelvic area, what we call as mesorectal excision. And what this has shown is that the surgery has become better and the results with it have become a lot better. Combined with neoadjuvant therapy, we are getting even better results. Now, for rectal cancer in particular, we talk about two different courses for neoadjuvant therapy. Now, how do we decide for neoadjuvant therapy? As I mentioned earlier, we base it on our radiological diagnosis, which is mainly MRI in this case for rectal cancer. And what we are looking for is we're looking at the tumor, whether it has gone outside of the rectum and whether it has invaded any of the tissue surrounding the rectum and has invaded into the lymph nodes. Now, if any of these conditions have been achieved from looking at the MRI, then these patients would require neoadjuvant therapy. Now, we do divide the neoadjuvant therapy into a short course and into a long course based on the amount of radiation and the time given and based on the staging of the disease. Now, in the short course, we do 7 days of radiotherapy, which is followed by surgery a week later. And the idea for this short course is we're sterilizing the area, we're getting it to be clean, which means we are trying to target those micro metastases. That means the smaller cells that we can't really see with our own naked eyes, but that have spread around there. So we're trying to target these areas. We're trying to reduce the chance for local recurrence. So that means after surgery, we are hoping that this cancer does not come back. Now, in the long course, it is a much longer time. It takes about 5 weeks. And the radiotherapy in this case is combined with chemotherapy to get the radiotherapy effect to be better or enhanced. And then only we do surgery 6 to 8 weeks. And we are basically targeting the same idea. We're trying to get the tumor to reduce in size. We're trying to get reduction in recurrence rates. And as I mentioned earlier, in many cases, we are trying to do surgery whereby we can save the sphincter and the control mechanism in patients with low rectal cancer. Now, when it comes to colon, there are possible benefits from doing chemo or chemotherapy mainly before surgery, but actually the efficacy of this, whether it is has it gotten to a level where we think it's very beneficial, I don't think it has been established yet. Now, the issue in these patients is that, as I mentioned earlier, the colon is large, it is long, it is traversing the abdominal cavity. There's a blood supply from many, many places. The lymphatic drainage, that means all the lymph nodes are also scattered and they can come from different angles and different places. So to target in a specific area is not as easy. And therefore, the results when it comes to neoadjuvant therapy have not been as good as it is with rectal cancer for the reasons I mentioned earlier. However, there are plenty of studies that are going on now, which start looking at what kind of subgroups that can benefit from this. And I think there will be one or two of them that will come out from this, especially those which are locally advanced disease, which is just confined to a certain space. It has not spread too far away. Perhaps these patients, we can still consider neoadjuvant therapy, and we are still waiting on the new research to tell us which patients are going to benefit from this. Now, having talked about neoadjuvant therapy quite extensively here, I do want to remind everyone that actually for colon and for rectal cancer, the mainstay of treatment is still surgery. Surgery is still the main treatment for these kinds of tumors. And the surgical options are available. And we have become really good at doing surgery for these patients from experience and from all the latest studies that have come out and all the new techniques that have come out. And we are doing surgery in both the traditional or conventional open techniques, and now we have the options of doing it with the keyhole surgery, and in fact we can also do these with robotic surgery now. So surgery is the main option. Oncological options in terms of whether it's neoadjuvant or adjuvant therapy, it is complementary, and we are finding that in terms of rectal cancer, we have gotten really good results in terms of saving the sphincter, in terms of recurrence rates have also come down quite a bit after doing this neoadjuvant therapy. So people tend to wonder a lot about how come I have to do so many scans, I have to do this scan, I have to do that scan. And the reason, especially in rectal cancer, is we are trying to get to the closest possible staging so that we can give them the option of neoadjuvant therapy, which we know has clear indications. It has clear benefits in terms of local recurrence, in terms of sparing the sphincters, in terms of overall benefit for the patient. So we need to do many scans for this just to get the right diagnosis and the right staging. In terms of colon cancer, the jury is still out, but there will be, I'm sure, after these studies are completed, there will be some subgroup that will benefit from this. And in terms of colorectal cancer, of course, I would like to remind everyone that the main thing is to have a screening. You need to check, and based on our Malaysian guidelines, everyone who's above the age of 50 should at least have some form of screening for colorectal cancer. In fact, I believe on the National Cancer Society Malaysia, there is an option of doing the fecal occult blood test as well. So I hope that everyone can get screened very early so that we can diagnose it early and we don't have to, a patient doesn't have to suffer from the consequences. I'm concluding my talk and I'm happy to take any questions.
Lovely. Thank you so much, Doctor. I think very enlightening discussion, and especially I think you've shed quite a bit of light on the neoadjuvant therapy and its role currently in colon cancer and in rectal cancer. And it's lovely that you have divided that proportionately, Doctor. There's a couple of questions, Doctor, if you're okay with taking some questions.
Oh, absolutely.
Okay, lovely, Doctor. There's one question from a viewer who asks, who actually is benefiting, who will actually benefit from the short course kind of radiotherapy in rectal cancer, and who will benefit from the long course radiotherapy?
Right. So I'll just start with the long course. So any patient who has what we will consider as stage 3 disease, that means the tumor, the cancer has gone outside of the rectum and has gone into the lymph nodes. So those patients will definitely benefit very, very much from neoadjuvant therapy. So these patients with positive lymph nodes, they will go for the long course. Now, the short course, the difference becomes is that these patients may have negative lymph nodes. That means we don't see the lymph nodes being enlarged on the MRI scan. However, there may be suspicion that the tumor might have invaded outside of the rectum. So these patients we will consider for short course radiotherapy. Of course, there are other criteria as well. For example, in terms of a short course, patients who have more than one tumor at the same time, what we call asynchronous tumors. Mm-hmm. Now, a patient who has a tumor in the rectum and another one in the colon, these patients cannot necessarily go for a long course, mm-hmm. because the long course will benefit the rectal part, but may not do anything for the colon part. So for these patients, we will, for example, we will opt for a short course for the rectal part, and without delaying for too long, then we can go ahead and proceed with surgical option. I hope I've answered the question.
Right, Doctor. No, you have more than answered the question, I think, Doctor. Doctor, there's another question, and this is on whether the mention there is on radiotherapy is largely being used in colorectal cancer for neoadjuvant therapy. Is there a role for targeted therapy or hormone therapy, as Doctor mentioned earlier, and how does it actually come into the picture?
I think this question would have been more befitting for Dr. Azura to answer. But as a colorectal surgeon, what we have followed so far is that we've noticed that with radiotherapy and combined with chemotherapy, there is what we've seen in many cases is that the tumor size becomes smaller. The lymph nodes, which have been positive on the MRI scan pre-treatment, have also shrunk post-treatment. So the benefit from that is very clear. Now, I wouldn't go as far as to say that giving targeted therapy or immunotherapy for these cases, because what I mentioned in my earlier slides is that to have targeted therapy or immunotherapy, you need the actual pathology. So you need the specimen to be out, to be tested for these kinds of treatments. Now, when we're talking about rectal cancer and neoadjuvant therapy, our treatment is based on the scan rather than on the tumors themselves. Exactly. So I think it is very difficult to say whether a tumor is going to benefit from immunotherapy or targeted therapy without having the pathological answers for that.
Right. Well do, Doctor. And I think that that's quite an important point. Doctor, I also want to ask you, and I think this is a very relevant point that you made, which I think we may want to highlight a little bit some more. I think even you and Dr. Azura this evening spoke about how neoadjuvant therapy actually plays a role in sphincter sparing for rectal cancer patients. And is this not a big kind of benefit that we need to highlight in terms of quality of life, Doctor? What do you think?
Absolutely. Now, just before I go into answering this question, I want to remind everybody that the focus of the treatment is cure. Now, cure means that whether we are doing neoadjuvant therapy or not, and when we are doing surgery, is that we need to make sure that we are getting a clear margin, or we are getting the entire tumor with all the tissue surrounding it to come out, so that nothing, absolutely nothing is left behind. So yes, we would like to have sphincter sparing. That means we want to save patients' control mechanism. However, if at any rate the main focus of having a clear, completely removal of the tumor, sphincter sparing becomes a secondary thing.
Right.
So as long as we are happy with our surgical technique being that we are going to be able to remove everything with good, clean margins, then yes, our aim will be to try to save the sphincter. But I still would I would hope that patients would understand that yes, sphincter sparing is important, but to be clear of cancer is actually the main goal.
Right.
So sphincter sparing is not suitable for everyone. However, there are a subgroup of patients with larger tumors closer to the sphincters after radiotherapy and neoadjuvant therapy. those have become smaller. It has enabled us to be able to sphincter saving surgery. Yes, we will definitely try to do that. And yes, it does benefit in terms of patients' quality of life. However, again, the reminder is the main focus, or the number one priority, is to be cancer-free.
Right. And I think that Dr. Osama has made like very clear on what the priorities are. And sometimes this is the concern among patients, the idea that, oh, I'm not so excited about going for this surgery because, you know, it will spare my sphincter. But I think it needs to be judged on the basis of life-saving versus sphincter saving. And in that sense, it's always going to be the priority for the treating physician, is going to be life-saving rather than anything else. Lovely, doctor. Thank you so much. I think very insightful for me as well, and I hope our viewers have kind of taken quite a bit of positive learnings back home, because I think the point of this evening's sharing in the session by Dr. Osama really is to highlight that, look, there is an idea that it's not about rushing into surgery. There is a very clear benefit in imaging, and imaging well. And sometimes it's not that you're unnecessarily being asked to image, especially in terms of rectal cancer. And in those circumstances, for those patients who this will be of benefit, neoadjuvant therapy is quite helpful.
Yeah.
Doctor, as we wrap up your session, really, could I get you to give us one takeaway for this evening, doctor?
Thank you very much for this opportunity again. And my take-home message is this: that despite all the research, all the studies that are there, I would like to remind all of our patients, we treat patients on individual basis. We look at these individuals as a whole, and we cater their treatment to what they require. And especially in cancer surgery, we always work as a team, as we do, myself and Dr. Azura. So our aim is always to give the best possible treatment available for those patients. Thank you very much.
Right. Thank you very much, Doctor, once again. And really, thank you for joining us this evening. And we hope to see you soon as well.
Thank you very much.
Thank you, Doctor. Okay, so that was Dr. Osama, and a very good evening once again. Dr. Anita, thank you so much, Doctor, for being patient and coming back and sorting out your slides. You muted as well, Doctor. So I'm just going to kind of...
Dr. Murali?
Oh, am I unmuted as well? Okay.
Yeah, Dr.
Yeah.
Murali, maybe
Yes, doctor.
I can try and share my screen again.
Lovely, doctor. Why don't we do that?
Okay, if I can't get it, then maybe you can help me with.
Can.
Okay.
No problem, doctor.
I'll do it again.
Share je. Pilih tu. Kan? Okay, cuba buka slide besar kan.
Okay.
Okay, lepas tu tanya yang dia.
Okay.
Okay, lovely.
Is that
got
okay?
it.
All right.
Yes, yay. Okay.
Yay.
Solid. Okay.
Okay, thank you so much. So shall I start now?
Yes, doctor, please go ahead.
Okay, all right. So my topic today is neoadjuvant therapy in breast cancer. And as an introduction, I think everyone should know that breast cancer is the most important cancer among women worldwide, including Malaysia, and the most common cancer among women in Malaysia. And our new cases of breast cancer had increased from the latest statistic from 32.1% in 2007 until 2011. Now it has increased to 34.1% of overall cancer among women between 2012 to 2016. This is reported in our National Cancer Registry, our recent publication. And as we can see in the slides, in the graph for female breast cancer, if we can see there, our stage 1 and stage 2 disease, which is considered as early breast cancer, is still the most stage of breast cancer that is diagnosed, which is about 52.1%. But looking at the graph as well, our stage 3 cases when they were diagnosed is quite high. There's definitely an increment. So as we know that typically in breast cancer management, the standard treatment is once we have diagnosed breast cancer through triple assessment, which include clinical examination, imaging, which is mammogram with complementary ultrasound or even MRI, plus tissue biopsy. Then if the patient is suitable for surgery, they will always go for surgery. And surgery, we consider whether they should undergo breast conservation surgery, which is wide local excision, removing only the tumor with some normal rim of tissue, or even a mastectomy. And for the axillary surgery, either they may go for sentinel lymph node biopsy or axillary clearance. Then after surgery, then only the patient will have adjuvant therapy, as presented by our consultant oncologist, Dr. Azura, earlier, which may consist of chemotherapy, radiotherapy, hormonal therapy, or even molecular targeted therapy. But in certain newly diagnosed patients, even at the initial stage of diagnosis, they couldn't go for surgery as a standard treatment first for certain reason. So in certain subset of cases, the patient will be projected for neoadjuvant therapy. Then only the patient will go for definitive surgery. As what we are practicing now, the best decision whether the patient should go for primary therapy, which is surgery, or either they should go for neoadjuvant therapy, the best is to be decided by a multidisciplinary team approach, whereby the primary treating clinician, which is who is the surgeon, together with the oncologist or even with the radiologist, we should decide and sit together whether the patient should go for surgery as a primary treatment or they should go for neoadjuvant therapy prior to surgery. So neoadjuvant therapy in breast cancer is defined as the administration of systemic treatment of breast cancer prior to definitive surgical therapy, which is given prior to definitive surgery. And typically, this neoadjuvant therapy taken the form of chemotherapy commonly, but the role of endocrine therapy is expanding in certain subset of patients, as in certain patient's condition which doesn't permit the patient to have chemotherapy, endocrine therapy may be considered. So the objective of neoadjuvant therapy in breast cancer is firstly is to downstage the tumor. What do we mean by downstaging the tumor is from a locally advanced disease, which is a stage 3 tumor or a tumor bigger than 5 centimeter in size, or the tumor is not that big, the lump is not that big, but the breast and tumor ratio is small, so we might consider projecting the patient for neoadjuvant therapy first. And the other condition is inflammatory breast cancer. I will show some pictures later on. And downstaging the tumor is meaning to convert inoperable tumors into operable tumors. And if the patient wanted to go or suitable to go for breast conservation surgery, we might convert them from having mastectomy to breast conservation surgery to improve cosmetic outcome and to reduce post-operative complications. And second objective is to allow an early evaluation of the effectiveness of systemic therapy, which permit the clinician to discontinue ineffective treatment. Meaning, when we decide neoadjuvant therapy for a patient, the patient should be monitored once they have started on the neoadjuvant, basically looking at the patient's the tumor clinical finding, whether there is tumor regression, which is becoming smaller, or the other way around. Okay, before we decide on neoadjuvant therapy, we should clinically stage the disease, whether it comes under early breast cancer or locally advanced breast cancer, which locally advanced breast cancer will need neoadjuvant therapy. So this is the latest staging for breast cancer from 8th edition of AJCC. Here, if we look at the picture, locally advanced breast disease is considered when the tumor is more than 5 centimeter in size, and regardless of the size of the tumor, but there's a palpable lymph node which is big and matted in the armpit. So how do we select our patient for neoadjuvant therapy in breast cancer? We should have decided when the patient is newly diagnosed whether the tumor in the breast is operable or inoperable. For inoperable disease, as mentioned earlier, they are categorized under stage 3 tumor. either T3 or T4 tumor, which is more than 5 centimeter in size, and these are called locally advanced breast cancer. And even many patients with tumors larger than more than 5 centimeter, which is under the category of T3 tumor, which is even actually potentially operable, are considered to have locally advanced disease. It means that even though if let's say a good breast size, but if the tumor is more than 5 centimeter in size, even if mastectomy can be done because of the high breast to tumor ratio, but we might consider it as locally advanced disease and suitable to go for neoadjuvant therapy to reduce the tumor size, and we might consider running away from mastectomy, and we might be able to do a breast conservation surgery for the patient. And the other type of inoperable disease when they are newly diagnosed is the inflammatory breast cancer. So this is a chart showing type of tumor size for the TNM staging just now. So T3 and T3 tumor is actually a tumor which is 5 centimeter or more in size, or T4 tumor, regardless of any tumor size, but it has invaded either the chest wall or the skin. And okay, all right, this is some pictures of inflammatory breast cancer, which appears overall redness of the breast, skin of the breast. And usually when we examine the breast, if in a patient with inflammatory breast cancer, it will feel very edematous, very swollen, and some of them can have areas of hardening, and it definitely doesn't look normal to compare to the other breasts. As you can see here, there's appearance like an orange skin, what we call as peau d'orange. Okay, just now was in a category in a patient which is categorized in inoperable disease, but in certain situation, even though the tumor is an early stage tumor, which is stage 1 or stage 2, which is considered as operable disease, but whenever as I mentioned earlier, if the tumor, if we are trying to get away from mastectomy to breast conservation surgery, even though the tumor is an early stage, we should, and if the patient is suitable for neoadjuvant therapy, we should advocate neoadjuvant therapy for the patient. And why do we do this is basically anticipating a better cosmetic outcome. Being said, trying to get the patient to have a breast conservation surgery rather than mastectomy if it is suitable. And in certain breast cancer subtypes, as mentioned earlier, for example, a triple negative breast cancer, which is meaning the hormonal status, which is estrogen or progesterone receptors are negative. And if the tumor is HER2 positive cancers, which associated with a likelihood better response to neoadjuvant therapy. So this type of tumor in a patient which should go for neoadjuvant therapy first rather than definitive surgery. And in a certain condition whereby the patient couldn't go for surgery for some temporary condition, For example, in certain breast cancer cases in pregnancy, so to delay the definitive surgery, some might be considered to have a neoadjuvant therapy. And all this should be decided during our multidisciplinary team meeting, together with the, to include, in the case of pregnancy, to include the ONG team. So before we proceed with neoadjuvant therapy, we need a pre-treatment evaluation which aim at confirming pathology and documenting the grade of the disease. And this will include definitive diagnosis of breast cancer, which will need a diagnostic biopsy. And we need to look into detail in the reporting of the biopsy results, which confirm the diagnosis of breast cancer. And we need an evaluation of receptor status as well as HER2 status. And this may allow us, once the diagnosis is confirmed, if let's say we want to run away from mastectomy in a bigger tumor and trying to achieve a smaller tumor size to allow wide local excision or breast conservation surgery, it gives us time to insert a radio opaque clip into the tumor, so that it will guide us. If the patient responds very well from neoadjuvant therapy, at least it will show us where the tumor base prior to the neoadjuvant therapy, and that will guide us how much and where to dissect if the patient has a complete response toward neoadjuvant therapy. And this will need the surgeon to assess the patient whether there's an axillary lymph node involvement as well. And we definitely need an imaging such as mammogram and ultrasound, and especially to look for any evidence of distant metastasis, and to assess exact size of the breast tumor, and is there any suspicious axillary lymph node as well. So this is an example of histopathology examination report, whereby the higher picture shows confirmation of invasive carcinoma. And this is how the second picture shows how our pathologists will report the patient's biopsy results to show us the receptor status, which is estrogen and progesterone receptors. For example, this is positive receptors, and CHERB-B2, which can indicate whether the HER2 receptors are positive or negative. So we definitely need this prior to neoadjuvant therapy. We need all the information. So the option for neoadjuvant therapy in breast cancer will include, usually most commonly is chemotherapy, and it can be certain types of chemotherapy that the oncologist will prescribe, and depends on what type of chemo. It can either be 4 cycle or 6 cycle of chemotherapy prior to the definitive surgery. And in certain situation, in certain cases, we might consider hormonal therapy as a neoadjuvant option. For example, tamoxifen or letrozole. And in a HER2 positive cases, this neoadjuvant treatment or neoadjuvant chemotherapy should be combined with HER2 targeted agent, which is trastuzumab, which is recommended to be given either concurrent with the chemotherapy or even after. Then once the patient had completed their neoadjuvant therapy, the primary treating surgeon should evaluate the response and decide on the management of the patient. And the best time actually to proceed with surgery is within 3 to 6 weeks after completing the last neoadjuvant chemotherapy. And we should assess the patient in terms of clinical assessment, which include physical examination to assess the tumor size, whether it shrinks or not. And besides physical examination, imaging is important as for surgical planning. If let's say if the tumor is smaller, then we might move from mastectomy to breast conservation surgery, or from a locally advanced, which we couldn't get, if we don't give neoadjuvant, we couldn't get a clearance, then we may move it to a mastectomy, which we can remove all the tumor microscopically and grossly. And this imaging may include mammogram and ultrasound, and sometimes we might embark on MRI to make sure that there's no tumor left over, or to look at the response after neoadjuvant chemotherapy or hormonal therapy. And this must include the decision on whether we need to do a sentinel node biopsy mapping, or we need to do an axillary clearance for the patient as well. And we need to decide whether mastectomy or breast conservation surgery for the patient after neoadjuvant chemotherapy. Okay, I think this is my last slides. There are some pros and cons of neoadjuvant therapy in breast cancer. And some of the advantages of neoadjuvant therapy is we can predict overall survival and recurrence. Free survival rate are similar to adjuvant therapy, meaning whether you give the new treatment prior to surgery or after surgery, it doesn't change your overall survival. And it serves as an in vivo sensitivity test, meaning if the tumor responds well from neoadjuvant therapy, meaning it's very sensitive tumor to neoadjuvant therapy that we have given, and it will follow with better outcome following further treatment after surgery. And from mastectomy, from neoadjuvant therapy, this will increase the rate of breast conservation surgery, and it facilitates the study of cancer biology as well. And we know that if they are suitable for neoadjuvant and they respond well, meaning we know that the cancer will respond well to other treatment as well. And the disadvantages of this neoadjuvant therapy is it modifies the stages of the disease, and we might delay the treatment for further adjuvant therapy after surgery. And with neoadjuvant therapy, even after surgery, we might left some residual intraductal component in the breast bed. And we might over-treated the patient if actually patient is not, the cancer biology is not suitable for neoadjuvant, but we thought the patient would respond, but actually we have over-treated the patient with neoadjuvant therapy. So with this, I conclude my presentation. Thank you.
Right. Doctor, thank you so much. Really forgive us for the hiccups earlier, but I think it's a very thorough explanation. I think very clearly put out to our viewers, and even for me, really helped me kind of put together the whole a complete understanding really of neoadjuvant therapy in breast cancer, Doctor. We're running slightly over time, but would it be okay if you took a few questions, Doctor? Just one or two? Okay.
Yes,
Thank you so much for giving us that extra time for us to kind of take questions as well, Doctor. First question is, there is a question from one of our viewers on what are the costs of neoadjuvant therapy in breast cancer? I know we will never be able to kind of compute dollars and cents, but is there an idea of it's 20% more expensive? That is there, or is there even a difference in terms of cost?
Okay, I think the best person to answer this is our consultant oncologist. Because either we give the patient prior or after the surgery, the drugs that we use, the treatment cost is still the same. I mean, the cycles that we are giving. So actually, it's it's a two different situation I'm giving here. If the patient goes to a government sector hospital or in a private setting, so it's different. But the drugs that we use, the actual cost is actually the same.
The same, yeah. Oh, okay. So that really helps to kind of put it into perspective, really, because amount of volume of in terms of the drugs being used, just to share with the viewers, we're looking at the same cost in terms of just the therapeutic costs.
Yes,
Doctor, if I noticed that you put up this thing about overall survival and recurrence-free survival rates are about similar. In that case, Doctor, why I mean, in your perspective, why would you even want to consider neoadjuvant therapy? Why would someone want to?
Okay, I think the most important thing here when we are treating breast cancer, if we need to have a good oncology clearance. If let's say the tumor is too big, and we won't be able to get clearance when we do surgery, that's the main that is the most important point in giving neoadjuvant, to make it smaller so that it's amenable for surgery first, or if it is earlier planned for mastectomy, we might be able to proceed with only breast conservation surgery despite mastectomy. So we are actually giving a better cosmetic outcome for the patient.
Right. And I think that's a really important point that doctor's trying to make, and it's worth to kind of strengthen that point as well, because as you can see, ladies and gentlemen, it's not really about what is this, making it prettier really, but it's about enabling better surgical outcomes, you know, to be put into for the patient, and that is an important game to play. I also liked, Doctor, the kind of point that you made on in vivo sensitivity, and how actually you can test this various, you put in a regimen and then you find that it's not working so well. Is there, in your own practice, has there been that you've started a patient during neoadjuvant therapy and that's actually, you find it's not suitable, and that actually that changes the subsequent management of the patient, Doctor?
Yeah. Usually, when we are starting a patient on neoadjuvant, we really need to monitor them up in terms of clinical findings, and mainly on clinical examination to look at the tumor size. And if let's say the patient doesn't respond well, meaning there's either it's stable tumor size, it doesn't improve much, it doesn't shrink, then we might change the neoadjuvant chemotherapy that we are giving. We might add on another treatment, or we change it. And even in certain situation, if the tumor doesn't respond, we might embark on surgery besides not completing the neoadjuvant therapy. So we don't want to delay any surgery, and we don't want to have a patient with disease progression with neoadjuvant therapy.
Right. Doctor, so as I mean, what would be your kind of advice to somebody who's just getting diagnosed with breast cancer? When should they have? Do you think it's worth for everyone to have this conversation with their primary clinician? Meaning, ask that question on whether, hey, do you think I would benefit from neoadjuvant therapy? Have that discussion. What do you think, doctor?
I think that is a very important what do we call this approach for a patient with that comes to us with breast complaint and diagnosed with breast cancer, and because we need to explain to them after, as Dr. Azura has mentioned earlier, our oncologist, a multidisciplinary team approach is very important. Once we have reached the decision, and we should discuss this with the patient so they understand, and they know that whatever stage of the disease they are diagnosed, there are still treatment for all these breast cancer patients. I think it's very important. Yes.
Right. Will do. Thank you. Thank you so much, Doctor. And could I ask you to kindly see whether if you can give us one takeaway message for us this evening as we kind of wrap up the session, Doctor?
Okay, since I am a surgeon, it might not be related to our new adjuvant therapy, but I think for all the ladies out there, or even men, please do come early for treatment, for evaluation if they present with any signs of or symptoms of breast cancer. And as if we treat them early, we diagnose them early, treatment is easier, and the outcome is so much better. And but for the patients that come slightly late than the meaning diagnosed at slightly later stage, no worries, because there are still treatment. Definitely is either it's to cure them, and we never stop with our treatment for breast cancer cases. Please do come early.
Right. Thank you. Thank you so much, Doctor. Thank you for spending the evening with us. And
Okay,
it's been
welcome.
really a pleasure. And really, I hope that for the viewers, this has been really a beneficial session. So as we wrap up today's session with our consultants from KPJ Ampang Putri, please allow me on behalf of the National Cancer Society of Malaysia to thank our consultant breast surgeon, Dr. Anita Bagawi, our consultant colorectal surgeon, Dr. Asama Malik, and our consultant clinical oncologist, Dr. Azura Daniel, for being with us on this session of Cancer and I. And of course, we'd really like to thank our supporters, Roche Malaysia, both actually all three, the diagnostic, the pharmaceutical and shared services arms of the group, for kindly putting the support that we have needed to kind of put this session together for all of you. You can, for those of you who missed or came in halfway, the sessions are on our YouTube channel, on our Facebook channel, as well as on KPJ Ampang Putri's channel as well. So please take the opportunity to go back and find and look this up and watch, especially all three of these sessions, and they're very enlightening insights for all of y'all. So with that, we'd like to leave you and see